All right, welcome back, everybody. My name is Lea Milligan. I'm from MQ Mental Health Research, and this next session of today's conference is a panel discussion entitled Data, Careers, Challenges and Collaborations. So if nothing else, it's a well-alliterated title. So I'm sure we'll have great interest. I'm joined by three fantastic panelists, Anne John, Jane Perkis and Dermot O'Reilly. I won't say too much more about them because part of what we're going to hear is a little bit of their own career journeys. Let me start by saying a big thank you to Jane, who is joining us from the other side of the time zone world. So appreciate greatly that you're up fairly late, I imagine, and hopefully you've enjoyed a bit of the Women's World Cup cricket throughout the day. I won't make a joke, Dermot, about the time zone that you're in being 25 years behind Anne's. That's a comment for another day. So the point for this session then is really to get the opportunity to hear directly from Dermot, Anne and Jane about their sort of career journey, what challenges they've faced in building the work they've done in data science, and some of the collaborations and hopes that they have for the future. This should be a fairly interactive session, so please do, as each of the speakers is chatting and I'm sort of presenting questions, please do put questions in the chat and we'll try to engage in as many of those as possible. To start with, what I'm going to do is ask each of the members of the panel to share for 5 or 10 minutes a little bit of their sort of career journey, to give us a context of where they've come from. I'll start with you, Anne, and then come to you, Jane, and finally Dermot. So a 5 or 10 minutes sort of initial share on your career journey today and what brings you to where you are. So Anne, let me come to you first.
Okay, so I started off career-wise as a medic, and halfway through the course we did this, we get to do intercalated BScs. I wasn't planning on doing one, and we all had to do a sociology exam, and back when you're really focused on the clinical aspect of medicine, a sociology exam is not a high priority. So basically the whole year read the book the night before, and just by chance I came top in the year, and that was literally, we were all reading it in the same place the same night. And so then I was offered funding to do this intercalated BSc, and I did it, and it just changed the way I looked at the world. And I went from, I guess, thinking very much about, you know, very fundamentally about disease and individuals in front of you, to thinking about things on a population level. And I guess that, you know, at first I did general practice, so I did all sorts of jobs, like obs and gynae and emergency department work, which I think does really give me an insight into the data that I do research on now, because as well as having a clinical understanding, there's also a real understanding of how messy it is, and how little regard when you're working clinically and you're like coding that, you know, and putting those diseases down, that you really don't care. It's like the last priority in your head. So then I did public health, which is where I learned all my epidemiology skills. And I think I probably would have stayed in public health were it not for an academic placement for 6 months at the university. And I think one of the things that is different about academia for me is that I am absolutely saying all the things that I said when I was working in the NHS. But I think in academia, you have much more opportunity to influence policy and practice on a larger scale to benefit the population. So for me, I guess that's how my career progressed. In terms of the topic area, both clinically and in research, I was always interested in mental health and children. some of the work on suicide came from that, because suicide prevention is so multifactorial. All the things that you do to prevent suicide have knock-on effects across the population in terms of mental health. But David Gunnell, who Jane and I work with extensively, actually marked my master's dissertation. And he reminded me many years later that it was on self-harming prisoners. And, you know, which wasn't something that was in my consciousness anymore at all when I started working in the field so much. So I think those interests have always been there. That was as much as I was going to say.
Brilliant, thank you. And I've got a few questions that have come into me on private message, but I'll hold them until we've heard from everybody. Dermot, let me come to you, and again, 5 or 10 minutes on your sort of career journey and what brought you to where you are today.
Thanks, Lee. Yep. Like Anne, I'm clinically trained, but unlike Anne, I didn't do any primary care. So I was a physician, and I was interested in livers, lungs, hearts, things like that. I'm sure if there was mental health around, we wouldn't pay any attention at all, because that's not what physicians did, certainly not back in those days. I then, like Anne, I segued a bit into epidemiology because I had to get a PhD, or a medical PhD, which is called an MD. And I got an opportunity to do one in cardiovascular epidemiology. And I just thought, well, epidemiology is pretty good. I guess I look at whole populations. And again, it's a bit like being a physician. The physician bit that I liked best was the diagnosis, trying to figure out what was going on, solving the problems. The treatments were a bit, well, whatever it said on the book, you did, that was fine. But the diagnosis bit, understanding that. And epidemiology was doing that for a population rather than individual patients. And that was brilliant. I then moved into service public health for a while, but then that changed and developed into contracting and contract monitoring. And I found that incredibly tedious. I thought I'm sure that's hugely important, but it's not for me. It doesn't rock my boat. So I then got back into academic public health and back into epidemiology. And one other thing that happened to me was when I went to do a master's in community health, as it was called in those days. I did it in Edinburgh. And I had a couple of lectures from the wonderful Vera Carstairs, who, and that's gone back a lot of decades. Vera Carstairs, the Carstairs Index of Deprivation in Scotland and so on. And she talked not just about deprivation, but about how she was using data, albeit at an area level, but in very novel ways, very powerful ways to understand more about the population. And I was hooked after that. And I brought all those concepts back to Northern Ireland and tried my best to try and understand as much as I can about the population using whatever data we could have to hand. So from public health, academic public health, and then over the last 10 years, nearly, I've been director of the Administrative Data Research Centre for Northern Ireland, one of 4 across the UK. And our job is to look at administrative data and to use administrative data to, again, try and understand policy, answer policy-related questions as well. No particular focus on mental health at that stage, but mental health kept cropping up. Well, we could very broad canvas. We look at everything from pollution to voting to benefits uptake and everything else in between. But mental health was there, both as a topic in itself, as an antecedent to many of the things that were going on in society, and as an outcome of many of the societal processes. It was unavoidable. And the old suspicion that mental health in Northern Ireland was perhaps worse than other parts of the UK, of course, attracted me. And there wasn't a lot of research being done here as well. So we were increasingly developing a strength and an expertise in utilizing whatever we could to understand mental health in Northern Ireland. So I think I'll stop there unless you've got other questions at that stage.
Brilliant. Thank you, Dermot. And Jane, let's come over to you. Let's hear a little bit about your sort of career journey today.
Thanks, Lee. Well, there's starting to be a few common themes, I think. So I'm a bit different to Anne and Dermot in some ways. So I started out in psychology. So I studied psychology, absolutely loved it in theory. And one of the things I really liked about it was that psychology is fantastic training if you want a research career, very, very good training in research. And I thought I wanted to be a clinical psychologist, but I worked in clinical practice for honestly about a nanosecond, and I hated it. It just wasn't for me. And it was for kind of the reason that Anne said, it was all about the individual. And I wouldn't have been able to articulate it at the time, but I wasn't very interested in individuals. And a bit later, not that much later actually, I had the opportunity to do a master's in epidemiology, and I just loved it. I thought this is all about population, so similarly to what Dermot's saying as well. For me, it was just so much more interesting, and there seemed to be so much more opportunity to, as Anne said, influence policy and practice, to do things on a bigger scale. And also, I was better at it. I was much better at thinking through the data and thinking about things at a population level than I was at working with individuals. I think I was a bit impatient, really. So I just loved it. But I also worked out quite quickly that it was good. And maybe this is a difference between Anne and Dermot's story. So the epidemiology masters I did was set up for medical doctors. So it was designed to attract medical doctors. Everyone else in the year was a doctor. And I worked out that it was, coming in as a psychologist, it was good to focus on a content area that I had some cred in. So I kind of got quite quickly into mental health. And in fact, I've really only ever worked in kind of psychiatric epidemiology, and mostly in suicide prevention, in the epidemiology of suicide and suicide prevention. And David Gunnell didn't mark my PhD thesis, but I did have the opportunity to look through my thesis again at one point. And I've cited David on just about every page. It was really quite funny. And he as Anne said, we work with him a lot, and he is just a model epidemiologist to look at, whose work is worth looking at. So that's probably me. The only other thing I would say is that as a tip for new players, if you're going to take part in a panel on data science, it's a good idea to look at the data. So when Anne said to me, oh, look, come and join us on this panel, it'll be in our afternoon, but we'll make sure that the timing works for you. I went, oh, yeah, sure, just do it as late as possible. That will be as early as me. But as it turned out, yesterday, when I looked at what time it would be, it was 2:30 in the morning. So I've been to bed and I've got up again. I'm fine. Don't look so worried, Anne.
Respect.
You're on mute there, Anne.
Early. I've had a full night's sleep.
Because Jane is a morning bird and I'm a night owl, we've worked together quite well across the globe.
You work we're awake most of the time at the same time.
Well, I appreciate the early bed and very, very early rise, Jane. Hopefully you get a I don't know, 5:30 nap.
I will go back to bed.
Yeah, before breakfast again. Yeah. So we've had a question come in from Katie, and it sort of chimes with the question I was sort of going to drill into and ask. And you've talked about, all three of you, this move into epidemiology to have a bigger impact on policy. And I suppose the way Katie's framed the question in there is, how do you ensure that that evidence can be translated? How do you actually drive that forward? Let me frame a sort of extra piece of that. How intentional do you need to be to make that drive forward, or is there a natural segue because the evidence being produced? I'll open that up to all of you for your thoughts.
I can have a crack if you like. So I would say absolutely you need to be deliberate about it. And the best way to be deliberate about it is to involve decision makers along the way, right from the outset, so that you make sure that you're answering questions that are of interest to them. And the other thing I'd say is that maybe it's a sort of a sad fact that the perfect evidence is never going to be the only thing that sways decision makers. So obviously you should make sure that whatever you're doing, you do as well as you possibly can and present the best evidence. But don't be shocked and surprised if there are a whole lot of other things that come into the decision making, like political will and community desires, those sorts of things.
Brilliant.
So I'd really like to agree with what Jade has just said. So I think in the first instance, some of those first relationships with policymakers can be by accident. It's a thing of timing. You've got a study, they're about to do something on it, or they're about to ask a question in Parliament, and you inform what they're doing. And then you build those relationships so that you can be having those conversations, so that you enter into doing that work early on in the process. But you know, as many of you know, over the last couple of years, I've, you know, been a member of SAGE and chaired SPI-B and things. And so I've seen a lot of that, that implementation and translation between evidence and policy. And it is sort of doing your best to present the evidence, but having a real understanding that what comes out of the other end of that pipeline might be quite different. And sometimes that difference is really appropriate because policymakers are thinking about broader issues. You know, they might be thinking about economic harms or other harms or budgets available. Sometimes you might, and this is one of the things I really like about academia, that you sort of have less of when you're working in some more statutory agencies, is you can be an advocate. And, you know, I particularly, you know, in terms of inequalities and socioeconomic deprivation and adversity, I've often been an advocate in policy making. So I think you do have to foster those relationships and understand the policy landscape where you are. You know, so you get a lot of, you look at a lot of grants and people don't even mention how it fits in. They might mention the Research Council strategy, but you don't see anything about the broader landscape and how the research fits into that.
Dermot, go ahead.
So, yeah, I'm reminded, Anne, of a comment by Nick Black at London School, who said there are two things you should never see getting made. The first is sausages, and the second is health policy. And I suspect that's true. The everything we do now as part of the institute that I'm, or the institution that I'm with, actually, we have to have policy built in. Administrative data research has to have policy built into all of our research. So it's we do that in a couple of ways. Every project we're starting or program work we start, we form a steering committee, not just with the policymakers and the data custodians, but also other stakeholders and the public and people with lived experience, all sitting around the table together. And we get closer and closer to a co-production model. I mean, I know it's a much bandied term. And indeed, actually, that's not a straight linear process. There's oftentimes a learning curve because there's a wee bit of resistance from the policymakers initially. Also a little bit of lack of understanding as to what you can do and how you can help them. And sometimes you have to show, you go around the circle the first time, show what you can do, show how you can actually help contribute to their policy making. And then there's a light bulb moment, and then they're quickly coming to, can you do for this for me? And it helps. And having the people with lived experience around the table with them oftentimes helps overcome the reticence to share data and to push what you can do with the data a little bit further, which is very helpful. And the other thing I'll say just to finish off here is that increasingly we're finding that you can use linked data to help link up policy and try and break down some of the silos between policy initiatives in government. Oftentimes, different governments have separate funding streams and the budgets don't cross over. But it's very clear that people's lives transcend those boundaries. And therefore, if you link the data across government departments, it's very clear that they've got to start talking together. And that can be very helpful.
Brilliant. Sticking on the go on.
Unless you were going to move on, I was going to just say something about the first part of Katie's question, because I think it's really important. We have more data than we know what to do with. And often you can do whatever you like, and the data sets are so large, you will find things. So in answer to that question about how do you address all the complexity, I think you have to come back to fundamental study design and case definitions. And if you get those things right, then the projects and the big data sets that we work with really work. But I think sometimes what you see is people are, designing cohorts, and they'll make a rule that lose 500,000 people that feels to them quite data driven, but actually it absolutely biases your cohort. So I think there's a real thing about the fundamental importance of having that basic knowledge of study design, which is very much part of epidemiological training. But I think sometimes for more pure computer scientists, it's not so fundamental to their training.
Well, and that kind of segues into one of my questions. I had listened to all three of you talk about your career path. So listening to your journeys, none of you set out to be in the types of roles that you're in now necessarily, and through trial and chance and fortune, this is where you've got to. By comparison, because we've been running conferences like this for the last few years, we've got an audience here who are already on this track and much earlier possibly than the three of you were on this particular track. Without suggesting that everyone takes a career break and moves into clinical practice or moves in a different direction for 5 years to get that experience, how do you make sure in this version of a career path you keep that breadth of understanding and keep that linkage between what the data science is doing and what difference that's actually going to make in real life? So how do you, if you're already on this path, gain some of the valuable assets the three of you have described in your journey if you're already on a different track?
I would say that it probably doesn't matter. I don't know whether Anne and Dermot would say the same thing, and I certainly don't feel like I wasted my time with the psychology bit of my career. But in the end, it didn't really matter. I might as well have just jumped straight into epidemiology, except that psychology did give me good training in mental health. So I don't think it matters. And I think that epidemiology specifically and data science careers more generally are by definition pretty broad. So the world's your oyster, really.
I completely agree with that. I also think that there's something, and I think, research councils and fellowships recognise this, about understanding the importance of working with stakeholders. So as well as people with lived experience with clinicians. And I think it's in this area, it's about, having that broad study team, but also getting involved in some of those workshops and focus groups that may seem a bit outside your skill set, but you'll pick up a lot of rich knowledge there about what's happening. And then I think making sure that the teams working on the data are diverse. So on my team, there are computer scientists, epidemiologists, clinicians, psychologists. We even have an astrophysicist. And so I think those are the ways that you can do it without sort of taking career breaks to sort of go and see what that life would be like.
Yep, full disclosure here. I before medicine did a year of included psychology. So I also understand that there are traits, personality traits that don't seem to change too much throughout life. And I think that's probably true for me in that even though I've been changing my job what I've been doing hasn't changed terribly much over time. I'm still, for me, asking questions or trying to spend some time getting the right questions in the right format and finding ways to answer them. And that's, I think, what a researcher is. I could be studying mental health or education or electoral reform. It doesn't, it's that research approach, that scientific approach that I'm applying. Just mental health is a really fascinating area to be in.
And that really strikes a chord, because I feel I'm doing the same things, which is about improving health, but at a population level.
And so moving to sort of more present day, we're looking at careers, challenges and collaborations. Andrew, at the start of the conference, said we've probably achieved more in the last sort of even 24 months than we have in the last 7, 8, 9 meetings before that. But what, interfaces between computer science, advancements in technology, and the recognition of the need, I suppose, are some of the big shifts and changes. What are some of the biggest challenges and frustrations you're facing today within the work that you're delivering?
I was thinking about this beforehand, because we were asked to just think about questions that you'd ask. And there are definitely challenges, and there are certainly challenges. There are things that make it easier coming into this kind of career now than when we did, but there are also things that make it harder. And it's hard, it's competitive, it's, funding is not always available for that fantastic study you want to do or that fellowship you need to keep going. So there are definitely challenges like that. And there are also challenges with just there not being enough time to do everything. So it's sort of maybe kind of conversely, actually. But I would say that the benefits absolutely outweigh the challenges. So, when I was trying to think of challenges, for me, mostly there aren't so many now. It's mostly I get to do this great job that I really like with great people, and you can't ask for much more than that.
What are your reflections?
So I guess research funding is a big thing. I think, mental health and suicide prevention research is sort of underfunded. MQ did their report compared to many other areas. I think that has shifted somewhat recently, the last 3 or 4 years. And, that's an opportunity. So while this is happening, we need to be grabbing and doing the studies that we want to do. I think one of the things that's happened during COVID is lots of barriers to data sharing have toppled. And I think one of the challenges going forward is to make sure that they don't all rise up again. And I think we have to be really aware of that. There are some legislative things that will change, like we've got COPI arrangements here about using data for COVID. But I think the repurposing of some of the big resources that have linked data across the country for mental health research is really important, and something that we're really supporting in DataMind, which is the HDR UK Mental Health Hub. And then in suicide prevention, thinking about, what are the challenges going forward? There was a paper published by a guy called Franklin, and I think it was prior to the pandemic, basically saying, we keep doing all this stuff about risk factors and we never change anything. And he had millions of risk factors in there. So I think one challenge is really thinking about, I don't think you can forget risk factors, because risk factors change. The emphasis, relationships, the patterns, the epidemiology changes. But we really need to be thinking about interventions. When you look at the Cochrane reviews, there's not a lot in there, really, considering. And then I think the other big question that's come up during the pandemic is we've seen all those cross-sectional surveys, some of which are deeply flawed, but some of which aren't, that showed a real increase in suicidal thoughts. And then, you know, the work that Jane's been leading on, and I work with her on it, we know that, you know, suicide rates, especially for the first year, stayed relatively stable, if not reduced. So we didn't know the answer before the pandemic. Becky Mars, who's here, did a really good paper showing substance misuse might be one of those factors on that pathway between thoughts and behaviours. And I think that's a real question for us going forward.
Brilliant, thank you. And Dermot, same question to you on challenge.
Challenges. Researching mental health is not easy, I find. Having done cardiovascular disease, touched on cancer for a while, it is much harder than either of those. I think that in terms of our understanding and our abilities or having the tools to explore, we are probably where cardiovascular disease was 30, 40 years ago. Still got some way to go. You can look at that with a bit of desperation, or you can look at that as a frontier country ripe for exploring and understanding. And that's where I am. Challenges are, yes, I agree with everything that Anna said, that things are getting better. There certainly is, COVID has been transformational. If there's been a silver lining, then that is potentially one of them. I hope that those don't recede, and indeed that the public pendulum, which has been so far very facilitating in terms of use of data, doesn't swing backwards where it was with careless data. So, however, there are still problems getting access to data. Most of the data mining that I do is with a pick and shovel, trying to get it from the clammy dead hands of the data owners. And that's tricky. And I was, as part of my wider job, was an example, trying to get help for a researcher in Scotland who has been trying to get access to Social Security benefits data and link those up with mental health data and indicators of mental health in Scotland, to see whether welfare reform, which was the biggest policy development in the UK before Brexit and before COVID threw things up, to see whether welfare reform, and especially the sanctions, had a detrimental impact on mental health and suicide rates. He's only been waiting for those data for 8 years. That's how long that battle's been going for. I have no idea how much it's cost in various meetings to get that. And still, we can explore nearly anything in the UK except poverty. And I suspect there are vested political interests at place to stop that happening. Second challenge is actually understanding the data when we get it, because of course none of these are not RCTs or surveys we've designed ourselves. It's an ongoing battle to once we've got the data, to try and understand, because there are nuances and differences and so on. And I have to keep reminding myself, and everybody works with me, get to know the data providers and make them your best friend, because that would be critical before you're going on. And the last thing I'll say is that, not a challenge, but actually an opportunity, is to work outside our own silos. That means across the UK and across the world. And by that, we can learn, we can increase our numbers and study smaller outcomes, more sensitive outcomes perhaps as well, but also we can compare outcomes. We can use administrative data and this approach to evaluate policy differences. So they're natural experiments, not perhaps RCTs, but we can learn from the different outcomes based on how people are handling things differently.
Brilliant. And I suppose you've finished there, Dermot, on a fairly upbeat note for a challenges-based question. So let me try to keep us on that curve as we sail into the afternoon. You've all kind of commented on the need for continued and greater collaborations. You've talked about this idea of, building really multidisciplinary, multi-skilled teams, and the advances in technology and skills in computer science obviously play a huge part in that, and being able to advance things more quickly. We've heard bits of that today in terms of NLP and other advances that wouldn't have been in place, even 5 years ago, let alone 10, 15 years ago. What are some of the collaborations that you're involved in that you're excited about seeing how they can develop, or what are some of the collaborations that aren't yet in play that you would love to inspire people today to maybe take up the mantle and try to build and construct? Jane.
Well, the study that Anne mentioned, which we've done, so we've done it twice actually. So we've gathered data from around the world on suicide numbers to look at whether the pandemic has had an impact on suicide. And particularly in the first year, the answer was unequivocally no, it hadn't. There's possibly a little bit of a shift in some places, but still they're in the minority as time's gone on a little bit more. But the process of doing that study has just been fantastic. So we've worked with collaborators. We've just submitted a paper which has, I think, 99 authors on it. Haven't actually counted the country. We've got data from 33 countries, but we've got authors from probably, I'm guessing, but maybe 60 countries. So it's been an absolutely fantastic collaboration. And some of those authors are data custodians. Some of them are academics who've helped facilitate access to data. But it's just been a brilliant exercise. There's so much goodwill, so much interest in answering that question that everybody was talking about at the beginning of the pandemic. Has there been this impact, or is there likely to be an impact on suicide rates? So I would say that's been a great collaboration, and more, and maybe it's because it is a really important policy question. So it's everyone's interested because the answer is useful for policy. We've talked about it, the finding a lot in terms of the mental health and economic supports that were put in place in lots of countries during the pandemic, and the extent to which they may have mitigated against suicide numbers increasing. So yeah, that's been a great collaboration.
Brilliant.
Yes, that collaboration from around the world and the depth of understanding that you have when you're working with people who know and understand their own countries has been, there were a few results where we were like, oh, what's going on there? I wonder what it is. And, you Googled about a country, and then the next day you're having a conversation with people from there and they've got a proper understanding of what's happened. I thought that was amazing. I think one of the things that has happened, and Dermot did touch on it. So a few years ago, we linked education data into the SailBuck data bank, and we did a study looking at mental health diagnoses in those who were excluded or absent from school. And I think those partnerships, and through that study, so, in the first instance, just trying to understand what that data set meant, because they were speaking a completely different language. Those partnerships through data, they lead into policy partnerships and policy interests. Those are the things I'm really excited about. So at the moment, we're doing a linked data project with prisons data, and another one with HESA data, which is the university's data. And I think it's some of those partnerships that sometimes it's almost like you see a shiny data set, and then there's a few people that, seem a bit more receptive when you've got your pick and shovel and you're having all those conversations. And those partnerships are amazing. And I think it's really for all of us to be agile enough. ADR does an amazing job of it, to be agile enough to sort of go into those spaces and work with people on their data to get insights that join health and other sectors. That, so governments often work in silos, and this is absolutely the way you address it.
Brilliant. And Dermot?
Yes, I'm going to go the other way from the academic. Academic collaborations are wonderful and increasing, and that's a sort of a given. But for me, the change was, as Anne said, it's the actual collaborations I think, yeah, rather just sort of interactions, collaborations now with policymakers, data owners, and around the steering committees and so on. That didn't come naturally to me, and as people who know me know that I would say that was not my usual modus operandi. I was more the publish the paper and be damned, and that's it, on to the next one sort of guy. But now I'm evangelical about the policy interaction, and it's brilliant, it's wonderful. The other thing I should maybe perhaps in passing though is put a shout out for is the all of the people who make this possible, the people who don't get mentioned, the people who put the infrastructure, maintain the infrastructure and the data that make all of this possible, because these guys get missed out quite a lot. There isn't a set career path for them, but none of what we do is possible without their input. And I think we should look out for them as well.
And absolutely name them on papers.
Mm.
You know, that there's a real, I mean, we get people to sign up that they have to do it in SAIL. And I think, you know, as we work more and more with data, you know, data managers, a good data manager, worth their weight in gold. And there aren't enough of them. You know, so I think it's not just building academic capacity. There's a lot of infrastructure posts that we need to work with, improve.
Can I just make a comment that's not related to collaborations, but it relates to something that Dermot said, which is one of the things that I wanted to make sure I said. So I think people in academia can get a bit snobby sometimes about, you know, it all being about publishing in top-tier journals and attracting funds from competitive granting sources, both of which are great. Obviously, you know, if you're working in an academic career, they're things that you should be aspiring to do. But working with policymakers, often, in my experience, the projects that I've done the best work on have arisen from funding that's come from a government department that wants an evaluation of a particular big program or an answer to a particular question. And sometimes there is this sort of, it's a bit unspoken, but there's this snootiness about that. And people think that's not quite such good academic funding and won't give you such good academic cred. But I can honestly say I have made a career on those sorts of projects. And they're not mutually exclusive. You can publish that work in really good journals. It's a bit of a mindset thing. So, and more importantly, those are the projects that often have the most influence, you know, in the real world. So, so I just wanted to say that, even though it's not actually related to your question, but something Dermot said reminded me of it.
And I guess for UK-based researchers, it's, you know, that's recognised in impact case studies, you know, that sort of work, because it's often government departments will expect, you know, something, you know, the funding is often not big, but it translates into papers, but also impact. And then, but my only proviso on that is I guess sometimes size matters. So I think in places like Northern Ireland and Wales, where we're a certain size, building those relationships with policymakers is easy. And once you're influencing policy and working in those arenas, it becomes easier to step into UK-wide, you know, bigger roles. But I think if you're in larger populations, building those policy relationships, you're far more distant from them. But it's sort of thinking about more local government agencies, and, you know, there are stepping stones sometimes.
Brilliant. Thank you to all three of you for your input and your time there, Dermot, and especially the night owl Jane for joining us crazy o'clock. Really appreciate that. And if you've enjoyed that session in particular, we've got a focus session next month for early career researchers, which will have a training and career path focus. So at the end of this session, check out more details on how you can sign up for that. Dermot and Jane, thank you so much for your input.